Evening everyone and welcome to the webinar on how to make sense of new data from ELCC 2026. Our program director is Dr. Amol Akhade. To start with the proceedings, I would like to invite our first speaker, Dr. Barnini Ghosh. Over to ma'am.
So today we are going to discuss the data which was presented in the European Lung Cancer Congress 2026 recently, and we have curated 5 highly practice-changing data sets for this purpose. So first, I will begin with a late-breaking abstract 5, which is about redefining the role of low-dose CT scan in lung cancer screening. So this was a study from China under the Lung Care Project, which evaluated the impact of one-time low-dose CT screening on lung cancer mortality in a non-risk-based population. It was a prospective, non-randomized controlled study, and this study has gained importance with the rising incidence of lung cancer among non-smokers nowadays. So what we know previously, that the previous lung cancer screening guidelines had recommended screening only in the high risk individuals, that is in heavy smokers, long-term smokers. However, with the rising incidence of lung cancer among non-smokers, this lung care project aimed to investigate the role of low-dose CT screening in non-risk stratified population, in the non-randomized population. So it included individuals in the age group of 40 to 74 years old, and they were divided into 2 cohorts. One was the screened cohort, uh, for the people who completed one-time low-dose CT scan, and another was the non-screened cohort. So the primary outcomes were lung cancer detection rates, and the exploratory analysis included lung cancer specific mortality, overall survival among all lung cancer cases. So if we look at the baseline characteristics of the participants, we can see that majority were in the 6th decade of their life, and a major percentage, that is 70 to 80% in both the groups, were non-smokers. They had no history of tobacco use. Now, if we look at the lung cancer cases diagnosed, so in the screened cohort, 81% patients were diagnosed with stage 1 disease, whereas in the non-screened cohort, around 51% of the patients, that is majority of the patients, were diagnosed with stage 4 disease. So we can see that in the screened population, the number of cases detected in the early curable stage is much more, and in both the groups, the number of adenocarcinoma cases were highest. So if we look at the uh, lung cancer specific mortality data, we see that the screening was associated with substantial mortality reduction overall, with a hazard ratio of 0.45, with a greater benefit observed in women, where there was 72% risk reduction, compared with men, where there was only 45% risk reduction. So the screen detected cases had better survival, with 87% 5-year OS versus 39% in the non-screen patients, with a hazard ratio of 0.13. And this is probably because 80% of the cases were diagnosed in the stage 1, where they were curable. So when we apply the NCCN and Chinese high-risk definitions to these individuals, we see that the high-risk patients had significantly poorer survival, with heavy smoking and COPD emerging as the key adverse prognostic drivers. And when when the lung care project data was compared with data from other benchmark screening trials like Talent, FANS, and NLST, it was seen that the baseline lung cancer detection rate was actually much higher than this NLST study population, where only the high-risk individuals were screened. The rates of detection were much higher. So, this actually addresses the fact that there is a massive gap in detecting cases when we are screening only the high risk population, because lung cancer incidence is actually rising among non-smokers nowadays. So this study addresses that. However, this study has its own limitations. Though it was a large study consisting of nearly 1,200 patients, it was a non-randomized comparison with potential for residual confounding between baseline and disease profile imbalance between the screened and non-screened cohorts, and the post-diagnosis survival analysis was vulnerable to lead time bias, length bias, and the risk of overdiagnosis. So it was a single region study and one-time screening study, which limits its external generalizability. So to conclude, the lung care project represented the first prospective non-risk based lung cancer screening program, which was associated with lower lung cancer specific mortality than that observed in a contemporaneous non-screened population from the same region compared with the traditionally high risk individuals. Non-high risk patients showed better survival and greater curative potential through early detection. Evaluation of screening strategies beyond the conventional risk-based criteria highlights the need for randomized trials in this population before broader implementation is considered. So next, we are going to discuss about a meta-analysis, the ETOP-Roche I times, which showed the non-inferiority of later versus earlier administration during the day of immunotherapy in lung cancer. So I'll begin with the background. It is that we all know chronotherapy, that is at what time of the day the immunotherapy or chemotherapy is being administered. Early versus late. Chronotherapy is an emerging therapeutic strategy that leverages the principles of circadian biology to optimize the timing of medical treatments, ultimately aiming to enhance their efficacy while minimizing side effects. Now, preclinical studies have suggested higher immune activation in the morning by various mechanisms, potentially enhancing anti-tumor response. So this was tested in a large meta-analysis consisting of Roche-sponsored phase 2 and 3 trials. So in this meta-analysis, matched cohorts were used. Patient classification was done by the timing of the first 2 cycles of immunotherapy. Um, the early group received immunotherapy before 12 p.m. and the late group received immunotherapy after 12 p.m. And these groups of early and late patients were matched by the study propensity score using gender, the presence of lung and liver metastasis, PDL1 status, etc. The primary endpoint was overall survival, and the primary objective was to investigate the timing of immune checkpoint inhibitor therapy early versus late in the day on overall survival for lung cancer patients. The secondary objectives were to assess analogous chemotherapy effect, assess the immune checkpoint inhibitor timing effect in other solid tumors. So the hypothesis of interest which was selected was basically a non-inferiority hypothesis that late immunotherapy is non-inferior to early administration of immunotherapy. And here the strict cutoff margin was taken as 1.18, which was the upper limit of the 95% confidence interval for OS, and this was more restrictive than the standard 1.2 to 1.25. So the primary result, if we see here, is that the hazard ratio crossed 1. It was more than 1. And the upper limit did not exceed the pre-specified non-inferiority limit, which was 1.18. So this study succeeded to demonstrate the non-inferiority of late versus early immunotherapy administration, and thus it primarily uh, supports this non-inferiority hypothesis. As you can see, the hazard ratio for overall survival is more than 1. So the primary finding was that the I-time study met its primary objective, demonstrated the non-inferiority with respect to overall survival, as I have already said, and this allows us uh, to uh, offer a flexible and pragmatic approach to treatment scheduling without compromising clinical outcomes. Now coming to the next study, the top trial, which was about previously untreated advanced, that is stage 4 or recurrent EGFR mutated non-squamous NSCLC. Now, what were the EGFR mutations taken into account? The most common exon 19 deletion or exon 21 L858R mutation having concurrent TP53 mutations, because we all know that when the EGFR mutations coexist with these TP53 mutations, they drive highly aggressive tumor biology and rapid acquired resistance to TKI monotherapy. So the top trial is the first to explicitly test whether upfront treatment intensification can overcome the poor prognosis of the specific molecular subgroups. And the patients had to have a good performance status, ECOG PS 0 to 1, and patients having stable CNS metastasis were allowed. So these patients were tested in a randomized multicenter open label phase 3 trial, and the randomization was done between two arms. In one arm, the patient received only osimertinib monotherapy, where it was continued till disease progression or unacceptable toxicities. And in the other arm, with osimertinib, the investigators had used 4 cycles of pemetrexed and carboplatin, followed by maintenance pemetrexed along with continuation of osimertinib. So the primary endpoint was PFS assessed by the investigators, and the secondary endpoints were overall survival, overall response rate, disease control rate, duration of response, safety, and patient-reported outcomes. Now, the patient stratification was done based on their performance status, presence or absence of brain metastasis, and the type of EGFR mutation present. So we will discuss that later. So here we can see that 294 patients were randomized, and of them 289 patients actually received treatment, and they were more or less equally divided in both the arms. In the combination arm there were 149 patients, and in the monotherapy arm there were 148 patients. However, if we look at the rate of patients who continue treatment, we see that 47% of the patients continue treatment in the combination arm, whereas only 24% patients continue treatment in the osimertinib monotherapy arm. So when we are looking at the baseline characteristics, I want to particularly highlight this, that the number of cases with brain metastasis were almost 50-50. So 48 to 49% of the patients in both the arms had brain metastasis present, and a huge percentage had extrathoracic metastasis, around 90%. So if we look at the overall response rate, we see that in the combination arm, the response rates were higher, 82.9% compared to 71.6% in the monotherapy arm. What is of particular interest is that the median duration of response. So the median duration of response is actually more than double in the combination arm. 32.7 months compared to only 15.3 months in the osimertinib arm. So more than double. And another thing to note is that there was no complete response in either of the arms. The complete response rate was absolutely zero. So looking at the PFS data, once again, the PFS was higher in the combination arm, 34 months versus 15.6 months in the monotherapy arm, which is more than double once again. And the hazard ratio was 0.44.
Barnini,
So if we look at
here
the
to wind
forest
up now.
plot, we see that the PFS benefit was consistent across all pre-specified subgroups, including those with brain metastasis. So patient with brain metastasis also had PFS benefit with this combination. Now regarding the overall safety, so the So the median duration of osimertinib exposure was 20.3 months, and the osimertinib monotherapy uh, in the osimertinib monotherapy arm, the duration of osimertinib exposure was only 15.4 months. Now, if we look at the grade 3 or more adverse events, so obviously they were much higher in the combination arm, 62% compared to a much lower rate, around 15% in the monotherapy arm. And treatment-related adverse events leading to
Requesting
dose
ma'am,
reduction,
ma'am, if you can just.
interruption, or treatment were once again much higher in the combination arm compared to the monotherapy arm. However, one thing to note here is that the safety profile in the combination arm, despite being higher, despite the side effects being higher, it was manageable. And adverse events related death occurred in only one patient in the combination arm. So the most common adverse events which were observed, which were manageable, were actually hematologic toxicities. Majority of the non-hematologic toxicities were grade 1 or 2. And in the osimertinib monotherapy arm, the most common toxicities were decreased lymphocyte count and diarrhea, and this side effect profile was consistent more or less with the FLORA2 data, and no new safety signals were identified. So to conclude, this top study prospectively demonstrated that osimertinib plus chemotherapy combination significantly improved PFS in EGFR mutated advanced NSCLC patients, non-squamous, who harbored concurrent TP53 mutations. And this benefit was consistent across all pre-specified subgroups, including those with brain metastasis. The OS data was immature at this interim analysis, but there was an encouraging trend of OS benefit with a hazard ratio of 0.57. And the safety profile, as I have said, was consistent with the FLORA2 studies, no new safety signals recorded. So these findings provide key evidence to support a molecular risk-guided individualized treatment strategy for EGFR mutated advanced NSCLC patients. Now next, I am going to G12D
Hello, Dr.
targeted protein degrader, PROTAC. So this is a uh, proteolysis targeting chimera. So what happens is that this PROTAC molecule actually has two binding arms. So you can see that this setidagrasib, it binds to the KRAS G12D on one hand, and on the other hand, it binds to. Yes, so this was a phase 1 trial which investigated this setidagrasib monotherapy, and so I'll just quickly rush through since we are. So
Yeah.
here, once again, advanced NSCLC patients were taken having KRAS G12D mutations who had asymptomatic treated CNS meds with a good performance status. And among all the dose range which was explored, this 600 mg IV weekly was selected for further study. And the primary objective was safety, the secondary endpoints being the ORR, disease control rate, duration of response, and the exploratory endpoints were PFS, OS, and the pharmacodynamics. So more or less, these are the patient characteristics where you can see that majority of the patients were PD-L1 negative, and 100% of them were previously treated. So this was a heavily pre-treated population, and the 6-month duration of response was 76% in the second or third line setting, which is unprecedented. And translational data showed that intratumoral cytotoxic T cell infiltration was increased in the patients receiving this drug, which had encouraging tumor immunomodulatory activity with a potential for deeper and more durable response. If we look at the PFS data, the PFS was 11.2 months in the second or third line setting, which was unprecedented once again because it is usually around 3 to 4 months. And if we look at the ctDNA associated clinical benefit, we see that patients who had more than 50% or more reduction in the ctDNA levels following exposure through the drug had better median PFS 9.6 months versus only 2.6 months to those who did not have such a significant response with a hazard ratio of 0.12. So cetidagrasib demonstrated a favorable safety profile. So it is not that we are getting the benefit at the cost of increased toxicity. The rate of grade 3 or more adverse events were low. No treatment-related death or discontinuation were observed, and the infusion-related reactions were low-grade, manageable, and mainly occurred at the first infusion. Antibody
We
drug
will
conjugate
move on to the panel.
which was investigated in a phase 3 randomized controlled trial of EGFR mutated advanced NSCLC, the OptiTrop lung 3 study. Now here, patients with advanced non-squamous NSCLC having EGFR sensitized mutations and who were heavily pre-treated were taken, who had good performance status, and they were randomized in 2:1 manner to the sacituzumab arm and another to the docetaxel arm. And what is important to note here was that if the patients in the docetaxel arm had disease progression, they were allowed to cross over to the sacituzumab arm. And the primary endpoint was ORR, the secondary endpoints wing PFS, OS, duration of response, disease control rate, etc. So if we look at the baseline characteristics, they were more or less equally distributed in the two arms. And if we look at the PFS data, the median PFS was much higher in the antibody drug conjugate arm, 7.9 months compared to only 2.8 months in the chemotherapy arm, and the hazard ratio was only 0.23. So looking at the OS data, the median OS was 20 months in the ADC arm compared to 13.5 months in the docetaxel arm with a hazard ratio of 0.63. Now, the overall survival data may actually be affected by the crossover. So, after using the specified RPSFT model, the OS data was adjusted for crossover, and it was seen like the curves had a huge separation after adjustment for crossover. The median OS was nearly double, 20 months compared to 11.2 months in the docetaxel arm with a hazard ratio of 0.45. And if we look at the adverse events, we see that it was actually lesser in the ADC arm, both the serious adverse events and grade 3 or more adverse events. So so the efficacy does not come at the cost of safety. And febrile neutropenia did not occur in the sacituzumab arm, whereas it occurred in 19% of the patients in the docetaxel arm. So to conclude, the results of the final OS analysis underscores this new ADC as a promising treatment option for pre-treated EGFR mutant NSCLC patients. Thank you.
Thank you. Can somebody load my slides, please? Thank you, Barnini. So, am I audible?
Yes, Dr. Amol, please go ahead.
Yeah. So I'm very sorry, we are already running late. So let me welcome all the faculty. I think Dr. Alfredo has not joined, but I welcome Professor Drew. I welcome Dr. Rami. I welcome Dr. Ullas. I welcome Dr. Sabita. And I hope Dr. Patrick will soon join us. Yeah, he has already joined. So thank you very much. So before wasting time, let us start. And I have, next slide, please. I have no conflict of interest. And as you know, we appreciate efforts taken by all trialists while planning and conducting clinical trials. And we thank all the patients who participate in these trials and believe that all trials, be positive or negative, are important in improving care for cancer patients. Next slide. So the important discussion as a thoracic oncologist, the breast oncologists are fascinated by mammography. If you got uro-oncologists, they consider PSA as sacrosanct for screening. But the important question for thoracic oncologists is screen or not to screen is the question. So next slide. In God we trust, all others we must bring data. So we have good data. There were two trials, National Lung Screening Trial, which showed 20% reduction in lung cancer mortality, and Nelson, which showed almost 24% for men and 33% for women in reduction in lung cancer mortality. And of course, there are a lot of retrospective studies also. Next slide. But there are too many issues, unfortunately. As with all screening trials, there is selection bias, there is a lead time bias, there is a length time bias, there is overdiagnosis bias. And of course, whether they only cause mortality reduction or improve the survival, that is an important question. So that is where the thoracic oncology is divided, whether we should use low-dose CT scan as a screening for lung cancer or not. So let me ask my panelists, Dr. Drew, I hope you're there. So next slide, please. So Dr. Drew, can I ask you, do you think lung cancer screening is useful and for high-risk patients or for all patients? There is a definition. This says that initially you start with 30 pack years, then 20 pack years, then 10 pack years, and then this was a study in which there were non-high-risk patients included, as was presented in this ELCC. So Dr. Drew, do you think lung cancer screening is useful, and do you practice in your own institution?
I mean, it is 100% useful. The question is how to do it. And the more important question is have we overcomplicated it? And as we complicate it and we have debates about it, meanwhile, more people die from lung cancer than the next several cancers combined. It blows my mind, the apathy, the lack of urgency to get screening to the right people, to confirm that it's safe, and when it's not safe, make it safer, so we can prevent mountains of dead people every year in every country on this entire planet. So the key issue is we really need to be screening the right people who would benefit. So in studies that screen younger patients, it makes a lot more sense. And the question is, how do you define who the right people are? We use this academic term high risk. Well, where did that come from? It came from the National Lung Screening Trial. And the PI of the NLST is right here at my institution at UCLA. And I asked Dr. Aberle, where did you come up with 55 to 75 and 30 pack years? She said, Drew, I don't know. It was just what everyone talked about at the time. We actually did this history study where we interviewed the older and oldest and oldest people who were there back in the 80s and 90s coming up with these definitions. And they told us that they did the best that they can. And pack year actually comes from COPD research. It's never really being studied that carefully to be the best measure of lung cancer incidence. So when I see the data that was presented here in study after study of study, if you're finding a 1.5% rate of pure adenocarcinoma, not GGOs, lipidics, those are real cancers, that to me, that justifies that we need to expand the definition of what high risk is. And it's not just smoking. You know, what causes lung cancers, as I tell my patients, is you have these little baby cancers that crop up in your lungs, and your immune system does a very good job of keeping them at bay. But eventually the damage to the immune system of your lungs let these things grow. And that could be, and we see it in non-smokers, right? People live in variable pollution areas. Guangzhou has variable, pollution. California has variable pollution depending on where you live. So we have to think broader, and we're having this discussion amongst oncologists. We're not the people actually driving screening, but we need to have a unified voice. And that slide you showed me really bothers me, right? But it's scary. Here we are arguing with each other while all these people are dying. So I think that, the current criteria, my institution, unfortunately in US, we're choked by insurance companies, and they have a definition, and so they use these rules. But if we want to use common sense and screen the right people, we need to be thinking outside the box and looking at these data with an open eye and having some urgency to figure out who to screen.
Dr. Patrick, what's your opinion on this? In your institution, do you do that?
Yeah, no, I agree completely. It's different worldwide, as Drew noted. So in Europe, as some of the most successful screening studies have been conducted in the UK, and some of the Dutch screening trial, the Nelson trial, was quite successful as well. In their wisdom, the European Union has required that each country conduct their own pilot screening study before a broad implementation. So we have a screening study. So the Dutch, ironically, are repeating their Nelson trial on a small scale to make sure that it's feasible to do. So it doesn't make a huge amount of sense, but that's what they're doing. So we have a screening study here in Dublin led by Dr. Addeo, which has been remarkably successful. I think the uptake is about 70% among the invited patients who are eligible. It's using the Nelson criteria for selection. And I think what you have to do really is go into the community and where people are, you know. So there's a mobile screening van that goes around to football games, to rugby, to different sports where people are, shopping centres, those sort of things, and that's shown very high screening rates. And we have had our first few patients come through the hospital with who've had detected stage 1 lung cancers, which is great to see. And so we recently had a patient actually who went from the screening trial and had a node positive stage 2 cancer and now has gone on to a neoadjuvant trial. So that's kind of the ideal situation to have, you know. But I think I would agree completely. The question is how we implement it and how we do it in a feasible way worldwide, you know.
Thank you. Thank you. Can I have the next slide? Yeah. So, Dr. Rami, this is one of the study conducted in US, and what's your opinion that your institution is being followed, and overall, what is your opinion about doing this lung cancer screening?
Yeah, thank you for
This
the
was
question.
presented in WCLC 2024.
Yeah, absolutely. Just echoing everything said, we're doing terrible in the United States overall. I'm in Florida, not just my institution, the whole state of Florida, less than 10% screening rate, from the criteria. This is just mind-boggling. This is not acceptable. I know we're at the other end of it. We're not the one in charge of it. We're not the one who's ordering. Education is needed. I understand a lot of effort. Some states are doing better. Some countries in the world definitely doing better. Again, we could debate the false positive rate. We could debate, you may be putting patient through some procedures or some invasive. But I think to me, considering like Dr. Moghanaki mentioned, is how the high mortality rate, the highest. I mean, we have patients through mammogram, through colonoscopy, which are way better. We're doing much better with those. And it's not just insurance company. Insurance play a part. Many initiatives, like the Kentucky one, which worked, but in other places not working. We have in Florida centers that would do for $99, which in the US is considered a low cost, just off insurance screening. And people are just not doing it. And we hear some different excuses. We hear, so we need to work with primary care doctor, with pulmonologist. We need to kind of clear those myths out there. Yes, there might be false positive. There might be some lung nodules that would make you nervous, anxious. I'm just repeating some of the themes that I hear, but it is needed. And at least, I mean, we're let alone in the smoker population. But I agree. I think with the pollution being a major factor, many other areas are risk factors. 15 to 20% of lung cancers are in the non-smokers. If it was for me, scientifically and psychologically, for me, I would tell every family member, every friend, every patient I know, every community, this needs to be a priority. And we're not doing a good job yet.
So far, all of us appears to be strong believers of the screening. So moving on, next slide, please. So of course, this study was well discussed by our colleague, Dr. Barnini. So can I have the next slide? So let me take a perspective from the low and middle income countries. Dr. Ullas, what's your take on this study and overall about doing screening in our part of the world?
Correct. So I think screening is important. There is no doubt about it. But we have to look at the resources that we have. And we also have to look at the comorbid conditions that we have. Now, in a pollution and tubercular endemic country like us, I think, and the cost constraints that we have with the government initiated screening. So there are two parts of a screening. One is if the government initiates it, government funds it and gives it to the people. Second is and we don't have any typical government related insurance schemes that we have, whether it is cost effective. Second is with so much of tuberculosis that we have over here, what is the rate of false positive and false negative that we need to really take a call. So on the whole, absolutely agree that we agree with screening, but the practical limitations of that, whether we need to screen everyone, like in this patient, in this trial design, there was one, there was one LDCT done, which was there for everybody. There was no, with Nelson, there was a high risk criteria, as they said. With the talent study, you had either a family history or a COPD exposure or something. So we need to determine the right kind of people. Again, in Nelson, they had 4 CT scans. I think in Talent, they had 3 CT scans, 3 CT scans to be done over a period of 4-5 years. In this, there was only 1. So the right frequency, the right population, the right cost of that remains to be seen, definitely in a LMIC country like us. But the results are phenomenal. There is no doubt that it needs to be done, but we need to, need to define the right population for it.
Thank you. Thanks. Moving on to the next slide, please. So, Dr. Sabita, you are from Tata Memorial Hospital, one of the leading cancer centers in Southeast Asia. What is your take? What's your institution policy about doing the screening in your institution, as well as overall, what you think? It will work in a country like India or Brazil, for that matter?
So as of now, we do not have an institutional policy of offering screening. Only if we have a patient who comes in who's concerned that they have been smokers and they don't have any symptoms, they are just concerned that they are smokers. We have an active preventive oncology department. So if they come to the preventive oncology department, we will offer opportunistic screening. Now, coming to applying screening on a national level in a country like India or Brazil, there is some literature from both the countries. First of all, from India, there is a study from PGI Chandigarh where they found nodules in almost 90 to 95% of the population. And this ended up clogging an already crowded system because you don't only need infrastructure, but you also need manpower. And now coming right from diagnosis to getting a biopsy done, to follow-up scans, and also having availability of treatment in terms of surgery, radiation, chemotherapy is not widely available. So this trial was stopped prematurely after recruiting some 300 odd patients. And there's also a retrospective study from Mumbai where they looked at CT scans done for different reasons and how many patients actually had nodules. So 90% of the patients had some changes, and they were very ably able to identify which of these actually needed a biopsy. The biopsy rate was low, but this was a retrospective study. Brazil did conduct 2 studies, BRELT 1 and BRELT 2. The first one was 790 patients. The second one was 3,700 odd patients. And they saw that in urban centers, it is feasible, even in a tuberculosis endemic country like Brazil, it is feasible with a low rate of biopsy. So even though they picked up a lot of nodules, they used, volume modeling and other procedures to identify these nodules and ended up biopsying a very small fraction. They saw that patients were being identified at an earlier stage. The survival was better, but they could never implement it nationally because when they decided to, roll out even in a small part of the population, the waiting list just to get a scan done was 90 days. So then if the patient requires a follow-up scan or an intervention, it is even more, it adds more. And so the anxiety associated with that, overdiagnosis, all these issues made it impractical for them to actually roll out this the screening at a national level. So I think in India, we are a long way away from offering lung cancer screening at the population level. We have to form some guidelines for opportunistic screening in a high-risk population, but in high risk, we have more and more data coming out in non-smokers, especially in Asians. So it's going to be very difficult to juggle and to find these criteria because we have high pollution in urban centers, but we have biomass exposure in rural centers. So it's going to be very, very difficult to juggle this. As of now, there are too many practical issues, and I don't think we are ready to implement this in India at least.
So thank you, all of you. I think the summary is that yes, lung cancer screening is important, and if it offered to right people at right places, it is good. But as everybody says, that in non-middle income countries there is a lot of issues. But at least in the higher income countries, I think that can be implemented on a wider scale. So moving on. Now moving on to, yeah, sorry.
Okay, just one point. I think there was a comment in the chat box about AI. I think that is the way to go. We need to do some kind of AI modeling, put in a lot of X-rays and CT scans, and then select the right population to which we screen. That should be very implementable in an LMIC country like us.
Yeah, so we have a trial running with IIT Mumbai, Tata Memorial Hospital Radiology Department and IIT Mumbai, where they are going to look at 3,000 scans and harness the power of AI to actually try and detect which of these nodules need a biopsy. So it's just started. Let's see what comes out of it.
So that's a very good
One last
point.
comment. If we can just uncomplicate it, make it simpler, all of these issues would go away.
Yep. So let's move on. Next slide, please. So now the important question comes to all thoracic oncologists, whether to give neoadjuvant IO versus perioperative IO. And this is a nice slide to show the summary and of all the OS data of whatever that is published as of now. Next slide, please. So let me ask, starting from Dr. Patrick, if there is an operable, medically fit stage 2 non-small cell lung cancer, no driver mutation, will you choose neoadjuvant or perioperative IO in your practice?
Yeah, well, can you hear me?
And let me tell the audience that Patrick is the PI of the neoadjuvant nivolumab trial. He's the one who got the 3-dose neoadjuvant IO in practice. So let us hear from him.
Or well, I think the for these patients over the last couple of years, we've moved towards recommending neoadjuvant therapy over adjuvant, and the guidelines in the US and Europe have also gradually shifted towards that as well. So the ESMO guidelines last year shifted towards preferring neoadjuvant for patients who are fit. I think the key thing is the patient fit for chemotherapy, because when we're giving neoadjuvant therapy, we're not just talking about immune therapy. They have to be able to receive platinum doublet chemo as well. But assuming they are, our approach tends to be to offer neoadjuvant chemo, chemo with immunotherapy, either nivolumab or pembrolizumab, or I think all of the regimens are quite similar. I think the bigger question comes up in the post-operative setting, whether they get the perioperative regimen or not. But in general, for a fit patient, stage 2 disease, who's eligible for chemo, we tend to do neoadjuvant treatment.
So what about, will you choose for only neoadjuvant approach, or you will go for perioperative?
Yeah, so that's a good point. I think, so currently where I work, it's predominantly neoadjuvant. For some patients, those who have residual disease at the time of surgery who don't have a PCR, we will discuss giving further treatment. But I would say we're probably 70–80% neoadjuvant only. Some patients will choose to have further treatment. There's some nice papers on this, but they're mostly retrospective, looking at the volume of residual cancer. There was a nice meta-analysis last year looking at the trials suggesting that those patients with some residual cancer, but not a lot of residual, so say they fit into the major pathologic response category, those may be the ones who derive a lot of the benefit from the adjuvant portion. So a patient, say, with 10%, 20%, those are the ones I tend to be more keen actually on further treatment. If the patient has a lot of residual cancer, say 70, 80, 90, 100%, then it suggests to me that that's a bad acting cancer and we need to probably think of something else. And if there's a trial available, which we have a number of, we will try and triage those patients towards those trials where possible.
So Dr. Ullas, what's your take? Neoadjuvant alone or perioperative for this patient, stage 2 fit medically?
So I think the first thing is, if a patient can ever afford immunotherapy to me, that's why I tell him, rather than giving adjuvant, I would want to give a neoadjuvant. Now, the second question is, patient has to come to us and say stage 2 diseases, which is very difficult. Even if he's diagnosed at stage 2, it will go to the surgeon first. So the surgeon has to be more than willing. But the standard line is, if the patient is eligible for immunotherapy, I would like to give it the neoadjuvant way. Between the neoadjuvant and the perioperative way, if the patient achieves a PCR, answer is simple. If the patient doesn't achieve a PCR, at least there is no pembrolizumab which is approved in our country for this. So right now it is checkmate 816 for everyone, and I think it is reasonably okay. If the patient doesn't achieve a PCR, I do counsel them for more immunotherapy, but at least neoadjuvant immunotherapy with checkmate 816 is something which I would prescribe.
So Dr. Sabita, Dr. Ullas mentioned that the patient has to first come to the medical oncologist. So do you think there is a role for upfront surgery and adjuvant IO? Patient is medically fit.
Yeah, so if the patient is medically fit stage 2 and no driver mutation, the guidelines say we have to give neoadjuvant, but there are nuances to this. First of all, the patient has to afford this. In my center, 5 to 8% of the patients can afford immunotherapy, even though it's only 3 cycles. And we don't have strong enough data for low dose right as of now. Trials are still going on. Second thing is, even if the patient is medically fit, you have to look at subtle changes in the CT if they have some interstitial lung fibrosis, interstitial lung disease. These patients will generally not do well with immuno if they have any endocrinopathies. So and the attrition rate in all the studies is at least 15 to 20%, which cannot be ignored. So you have to counsel the patient in an MDT, give them both the options, and then see what the patient chooses. Most often in India, we will get the patient saying, no, you decide for me. So we take a risk-benefit ratio and we try and tell them, but if there are any comorbidities, patient has borderline fitness, borderline fitness, not resectability, sorry, borderline fitness, I would ask them to undergo upfront surgery. But if the patient is fit, will be able to tolerate multimodality treatment, then we'll go ahead with neoadjuvant IO. That being said, in stage 3, there is no option. You have to urge the patient to take neoadjuvant.
We will come to that. So, the next slide, please. So, Dr. Rami, now, of course, we have a cost issue, access issue in India, but what about the center we practice? I don't think so. There is an access issue. So, what's your choice? Neoadjuvant, perioperative? Do you think PCR matters?
Yeah. So happy to take the next hour if you give me to talk about this topic. Just kidding. This is the debate du jour now. I do want to comment, on a very important thing. You guys bringing up obviously the priorities in different parts, because in the United States, neoadjuvant is approved, peri-op is approved, so we rarely deal with insurance issue, although we do. I'm originally from the Middle East, from a country called Syria, where immunotherapy is barely existing and very hard to afford, so I definitely feel. But leaving that aside, sadly, I would say in the US, that's the debate du jour, neoadjuvant only or peri-op. I'm definitely a big fan of no upfront surgery. I think the data is clear with any disease or any lymph node disease. I don't think they should get upfront surgery. As far as the neoadjuvant versus the peri-op, I think the jury's out. We do know that the component of the adjuvant portion has not been looked at prospectively, as Patrick mentioned, Dr. Foley. So we're in desperate need for trials. We don't know if we have this trials. There has been, as he mentioned, a nice attempt. It was criticized comparing Checkmate 816 to Checkmate 717, which was the same group, the same team, the same company, looking at some comparison. I do feel there are some take-home points in my clinic, just to save time, is I discuss neoadjuvant for sure, refer them to surgery, make sure they're a surgical candidate, regardless if they of the neoadjuvant or giving the neoadjuvant with a goal to turn them resectable. They need to be at least resectable. I am giving neoadjuvant, I am giving 3 to 4 cycles of chemo IO, and then yes, I can have a hard stop after surgery. I look at pathological staging. I look at how patient did with immunotherapy. I look at their what kind of response they got and PD-L1, and I try to come up with factors. As of now, I lean towards some major very response. PC consider stopping those some response, not great response. Maybe from any response, minimal response, maybe like mentioned, I don't think it's adding much more to them. We should intensify. We do have some trials looking at certain things. But as of now, my answer is PCR does matter to some degree.
Thank you, for this response. Dr. Drew, what's your take on this? Can I have the next slide simultaneously? So, Dr. Drew, do you think PCR matters? Because there's some data to some slide or some discussion to say that whether this particular trial, which was presented here, there are some issues, some of course not very minor points, but overall, do you agree that PCR matters?
So as a radiation oncologist, I don't make that decision with my patients, but as a multidisciplinarian, I can describe to you what I'm hearing across the US, both in my academic practice at UCLA and across the VA healthcare system where I also practice. And generally speaking, there is sufficient uncertainty, I think, as Patrick alluded to, about whether more is going to help, right? If PATH-C already occurred, then is there any more disease? If you eradicated the visible disease, is it possible the invisible disease lingered around and a few extra insurance infusions are going to help? there are many people who are designing trials where they're randomizing patients with PCR to more versus none, just stopping at that point. I don't know where they are in their status, and we don't have the data from it. But again, there's sufficient equipoise to randomize. And if I was on a steering committee for that, I would be very comfortable with that. And then the question is, if it didn't work for the visible disease, it very likely didn't work for the invisible disease, and we should be treatment intensifying with something else as opposed to giving the same drug. And of course, the biggest question of all is, can you really cure cancer with 3 cycles of immunotherapy? Well, as many of these studies have shown, the answer is actually yes. You do have complete eradication of disease, which is 3 or 4 cycles of disease. So it's a very tough situation. And I think that in many situations where we don't know what to do, we really need to prioritize safety over just giving more to feel better about ourselves.
Thank you. So moving on, can I have the next slide, please? I think we have discussed this. Next slide. So coming to the most important thing, and that is the most important controversial thing right now, what is your definition of resectable stage 3 non-small cell lung cancer? And this is the guideline which has been published, I think 2 days back in Lancet Respiratory Medicine. This was presented, I think, last year also. And very peculiar thing to show about potential resectable. And in one place, they say clearly unclear. So what's your take on this, Dr. Drew?
Well, there's only one test you can order to confirm if the tumor is resectable or not, and that's a thoracic surgery consult. The surgeon is the only one who can tell you, I can get it all out. And I actually wasn't at the table with this committee, but if I was there, I would ask a very important question. Why are we misusing the word resectable? The surgeon can clear N3 disease. They can clear bulky N2. You know, you can put a patient on bypass, stop the heart, and resect the tumor that's invading the pericardium or whatever that would be technically unresectable in this table. The question really is, should we put the patient through surgery? You know, is it really going to help them? And if you unwind history, go back several decades, this term emerged out of studies that showed 100% relapse in when you operated on the wrong person. So then the question is, why don't you just put that person through anesthesia and a 6-month recovery period, and they still died of their cancer? So it's really, we should not be operating on these people, sort of a question. Now, that definition comes from the past, and I think that, you know, a lot of guidelines committees, they're beholden to having evidence to support their opinions. But today, it's a completely clean slate. We are seeing past CRs in 3B disease. So why aren't we aligning that patient for a drugs and surgery standpoint? The challenge is people like to sit at a desk and write these papers about a guideline that's going to save the world. If you talk to a good academic surgeon, they'll tell you, you know, it's not good. There's no one size fits all. So each MDT really needs to calibrate its skills, its talents to decide who it thinks it can operate on safely or not, and whether it would help or not. And you need to look at the whole NGS to predict whether you can really clear this disease or not. If you've got a bunch of really bad co-mutations that are predicting for small cell transformation, for example, like you really need to think twice about it. So it's very confusing, and I'm not really excited about this publication.
Dr. Patrick, what's your view? Do you agree with this table, and this is what you follow in your practice?
Yeah, no, I think Drew, to be fair to him, makes some points there. I think well, the issue is that this question of resectable, that like they don't really get into the technically resectable versus medically resectable, you know, and there's two elements to that. Like technically, can the surgeon remove things? Well, I guess if you're doing extensive enough surgery, you can. There are some questions, so you'll notice they're quite concerned about bulky N2, and these are often kind of matted nodes, big nodes throughout the mediastinum, and even the most optimistic surgeon might find it difficult to remove those. But on the other hand, with chemoimmunotherapy or even in the targeted therapy settings, we see radiographic partial response rates of 50% above plus, you know, and the question is, should we really be assessing resectability kind of on the baseline, or should we be, particularly for higher risk patients like stage 3 disease, should we be giving the best systemic therapy first and then coming in with the local therapy, albeit with the risk that a small number of patients, hopefully a small number of patients, may have primary progression of disease. Now, oncologists traditionally have argued, well, if the cancer is so aggressive, it's progressing on 2 to 3 cycles of chemo IO, maybe maybe local therapy was not the best idea. But I suspect in the longer run, some of the clinical trials may move towards your best systemic therapy first, and then your best local therapy, depending on the response to systemic therapy for stage 3. I'm not a huge fan of kind of consensus agreements on resectability, because every surgeon, even within the same hospital, they can have different opinions on what's resectable, you know. So trying to set something in stone is quite difficult, you know.
Yeah. So can I have the next slide, please? So let me involve our surgeon here, Dr. Sabita. What's your practice in an institution? And do you believe that there is downstaging and conversions can occur? The potentially non-resectable can become resectable?
So first of all, the guideline which we were talking about, it's a consensus statement and not actually a guideline. And I agree with both the previous speakers, Dr. Patrick and Dr. Drew, that resectability lies in the eyes of the beholder. It's a subjective thing. It's not objective. So when you refer a patient to a thoracic surgeon who's going to talk about resectability, you have to first make sure that they have audited their morbidity and mortality, which has to be in today's world less than 1 to 2%. If they can perform MIS, which from the recent data has shown that VATS reduces mortality by 20%, and also if they are high volume. If you meet all these 3 criteria, you can be assured that the definition of resectability you get is most likely going to be aligned with the correct definition. Then coming to bulky, which is unclear in T2, T1, N2. So bulky lymph nodes mean lymph nodes which are more than 3 centimeters, or they are infiltrating surrounding structures. So at this point in our institution, if it is a single station bulky lymph node, we will definitely send the patient for neoadjuvant, chemoimmuno if possible, and then reconsider for surgery. But anything that is non-bulky, small lymph nodes incidentally detected on EBAS, if they are single station, definitely it will come within the purview of assessing this patient in a MDT for surgery. Multi-station and non-bulky is another unclear idea, but there are certain situations. For example, if you have a 2R node, upper paratracheal lymph node, inferior pulmonary ligament lymph node, which are at 2 ends of the thorax, and a lower lobe primary. So most of the times, at least our radiation oncologists find it difficult to encompass such long radiation fields. So in this case, if the nodes are non-bulky, there is a role for surgery even in multi-station non-bulky lymph nodes. So you have to find the correct surgeon, and you have to always discuss this in MDT is my take. Whether we can convert unresectable to resectable is not well defined at present, but borderline resectable to resectable is definitely happening, and there is a surgical creep even towards stage 3B disease. So we are getting there, but you cannot have a cowboy attitude towards it. You have to weigh the benefits and pros, and always discuss in an MDT where there is a radiologist also present.
Thank you. So looking at another next slide. So Dr. Drew and Dr. Ullas, I wanted to honestly tell me what happens in an MDT. Dr. Sabita is talking about MDT. So who decides in an MDT? Is the senior most voice, or the loudest voice, or of course the surgeons? Dr. Drew, I'll start with you, and then Dr. Ullas, and maybe Dr. Rami also can contribute. What actually happens in the MDTs?
Well, the surgeons, of course, is what most people think, but the surgeon can isolate themselves if they are bullying the MDT. The MDT now, I think, stronger than ever before. So the surgeon is increasingly diplomatic in our conversations. And you see the girl to the left, the woman to the left, sometimes that's, you don't want a situation where someone has to cover their ears. I think that the person who emerges as the voice of reason sometimes is maybe the person here that's described as the senior most voice is the person who looks like they're not a surgeon or a medical oncologist or radiation oncologist. They're just wise. They've seen people get hurt, and they really care about the safety of the selection of treatment. And we see this sometimes where the surgeon says, yeah, I can take it out. And then the medical oncologist sometimes it's not even their patient will say, but this patient look, they're 82 years old or whatever it is. So I think that it is kind of an organic thing. And I would encourage everyone on this webinar to listen for the relationships in the MDT. And if there is animosity between 2 different individuals or different groups, if there's tribalism happening, fix that. You can't move forward when there are these sour relationship. Iron it all out so people can have healthy, transparent conversations that are honest. And that's really the best way to make that decision. And every case is unique. And I love our pneumologists, our pulmonologists, because again, they don't have a horse in the race, right? And so they often come and you want to create a safe environment where people ask questions. And so in my MDT at UCLA, for example, I am so proud to say our medical oncologists often ask about, well, what would radiation look like? I often ask my surgeon, hey, how would you resect it? And is that an incomplete fissure, and what are the implications of that? And the radiology, and everyone's kind of listening and learning each other's language. And I think that's the best way to decide an MDT.
Thank you. Dr. Rami, in your institution, what happens for Pacific versus Keynote 671 for 3B or 3C? How it's decided?
And for the sake of time, I agree with everything is done. It's a multidisciplinary try.
I think there is issue with your voice, audio.
Come closer to the microphone, maybe. It's still garbled.
I think. Okay. So can Dr. Ullas, can you pitch in what happens? What in your institution? Pacific versus Keynote 671 for 3B or 3C?
So what we have in our MDT is fun. We have fun.
Okay.
So that is what exactly Dr. Drew said. As a medical oncologist, I'll ask my surgeon, okay, Dr. Daglang, what would you do? He will take puns with the surgeon, the radiation, the Dr. Shafal, and the pulmonologist comes in and the IR people come in. So we just have fun. But I think we have by and large grown over time, and we have realized let's have honest, transparent discussions. There is no bullying anyone. I'm sure that I've passed Dr. Drew's test right now. It's not the surgeons, it's not the senior most. I think it's the loudest and the wisest, which predominantly is a medical oncologist, I will say. Being a medical oncologist, pun intended. But I think we are all friends. We just come and have fun over there with an intent to give the best treatment to the patient so that everybody wins in the end. And that's what we do.
I really think the concepts about surgeons being the bullies needs to change. I mean, I
look at me. I knew that.
I don't think that's true anymore. And we are an evolved species now, and we are capable of having, polite dialogue also. So please come to my MDT and we will find out.
Medical oncologists are turning into bullies now, Dr. Sabina. Sabita, if that is what you're saying.
No,
yes.
I'm not saying that. I'm just saying I am capable of having a polite discussion, and so is everyone.
Fantastic. Thank you. Thank you. So let's move on.
But I would like to just say one thing. So the title of the slide does say 3B and 3C, and I'll let you know, at our institution, we do not. We don't go across the line because we have a medical legal problem. If there's a bad outcome that the patient sues the surgeon and the team, the whole institution could be liable for trying to do something which we actually think is experimental. We think it's experimental to be doing these things until there's more trial data. That's just what our institution is.
Thank you.
Right.
Thank you. So moving on, I think let's quickly wind up. We have, of course, good data about additional local RT in NorthStar trial. Next slide, please. So I wanted to ask, Dr. Rami, I think you're there. What's your take on giving local RT to the metastatic EGFR positive patients? You give it to all, you give it to those who are responding well. What's your take on NorthStar? Dr. Rami? Is he there?
We completely lost his voice now.
I think
Can't hear
Rami,
anything. Zero.
Yeah. I'm very sorry. I think Dr. Rami, we have lost your voice.
Can you hear me now?
Yeah,
Yes.
I can hear you now. Please.
Okay, very good.
Please, Dr. Rami.
Yes, absolutely. Thank you. Yeah, so just a quick sentence on the prior one. We in our institution also do, of course, no bullying. It's a team. As long as we all remind ourselves that the best interest of the patient comes first. I do like to say, as a medical oncologist who is involved in the Pacific trial, chemo rad followed by consolidation, and the neoadjuvant versus surgery, I found myself often kind of able to tell the patient, look, I see patient going in pathways and I'm not biased, in case the patient feels sometimes that the rad onc or the surgeons are biased, although I believe in our institution they're not. I just wanted to comment on that. So the medical oncologist could be the common denominator. As far as this trial, I am very supportive. I'm a big fan. I'm a believer that consolidation radiation or involving radiation in patient with metastatic disease has a role. We have some data to tell us. One of my colleagues that I respect, one of my mentor, you would say that any patient with stage 4 that does well for a long time, if you go and dig deeper, they must have received some radiation. And this is whether the consolidation radiation for those who have limited metastatic disease or oligometastatic, or also those with oligoprogression. I think those who respond well, I definitely refer them, at least for the discussion. We bring it to the tumor board. I'm always a fan of starting systemic therapy first. Let's cleanse, let's go after any micrometastatic disease. Let's make sure we are hitting the cancer hard with systemic therapy such as osimertinib. Now we're going to have osimertinib chemo, mariposa, etc. And then if they have a good response, let's give the benefit of the doubt and ask my radiation oncology colleagues if they could radiate a few lesions to add and consolidate on the motherhood tumors and some other metastatic disease.
Thank you. Dr. Akhil, what's your take? Dr. Akhil is our young dynamic medical oncologist from another prime institution, that is PMH at Varanasi. Dr. Akhil, what's your take on the local RT?
Yes, sir. So definitely incorporating radiation at correct time and correct patient is the key. So it is not for all. We need to select the patients well. And as it was already highlighted, patients with only thoracic disease, patients who have limited sites of disease, I think definitely there is now enough data to suggest that consolidation RT will help. So we need to be carefully utilizing this modality into the treatment of even metastatic disease.
Can I have the next slide, please? Dr. Ullas, a quick word from you. Why this doesn't work in other mutation subtypes? What is only working in EGFR subtypes? Why not in ALK, as the data shows?
So I actually don't totally agree with this statement. It doesn't work in other mutations. Actually, it so we need to be cognizant of the fact that this will act for what time? 7 months, 8 months, 10 months. This is not going to turn you into a 2-year advantage or something. So probably if you can see in this 7 months and next systemic therapy 10 months is reasonably okay. So I do think it also depends on what salvage therapy do you have also. Maybe let's say you have given crizotinib and you have lorlatinib, or you have repotrectinib and ROS. If that is also good, it is okay. Again, depends on the right patient, as what Akhil said. But I do think it should work. I mean, we do apply this concept of oligoprogressive or oligo-residual disease and giving conservative RT across all the gene biomarkers. We don't only apply it to EGFR. That's my take on that. We'll be happy to hear Dr. Drew's views.
Yeah. Dr. Drew, what's your take? Dr. Drew, Dr.
Well,
Rami, what's your take for other mutations?
The challenge of, so we know it helps a lot of patients. I liked Dr. Rami's statement that the patients that do really do the best have had some radiation along the way. And the key thing is not to hurt the patient, right? So if you've got a big, large tumor, you're going to cause pneumonitis. That pneumonitis then might preclude TKI or immunotherapy administration, so safety, again, safety is so key until we have the right NGS or blood biomarker to predict who's going to benefit or not. And then meanwhile, we just have to remember, if a medical oncologist had a drug that they could infuse into the patient that would just go to the visible tumor, they would be prescribing it all the time. And that's what radiation therapy is. So it's a very effective cytoreductive treatment. And when we think about all the pills and IV infusions that we give, we're cytoreducing. So it's just one more cytoreduction. I've had patients, I've cytoreduced 12 different targets. And 18 months, 24 months later, they're still on their osimertinib. And then with the ALK patients, it is a little bit more tricky because they're, I'm more careful watching them. And I rather treat the ALK patients with those TKIs at time of progression.
Thank you. So I think we are running out of time. Can we have
can I make a statement, Amol? Can I make a statement on this?
Yeah, please.
So my concept, and whenever we discuss oligoprogressive disease or oligo-residual disease in MDT, is it will make a good disease look better. local treatment will not make a bad disease look good. So we are only going to make a better treatment best or a good treatment better. And that is how we act.
Yeah, I fully agree. So can I move on some of the slides and let's go next slide, please. Next slide. I think we will skip this part. Next slide. Next slide. Let us come to the most interesting presentation. Next slide, please. Yeah, the eye times. Yeah, the previous slide. So the eye times, the study, which had shown that there's a lot of buzz about whether to give immunotherapy in the morning or in the evening or what was better, but this has debunked that myth. So can I have the next slide? So let me ask, if you see this slide, this very clearly shows about the half-life of various drugs. So let me first ask Dr. Sabita, why do you think that when you know that the half-life of drug is so long, whether to give it in morning or evening doesn't make a difference? So why there are so many studies, so many bugs?
I would like to take back my statement. I'm a bully, I'm a surgeon. I don't know much about this. I'm not that knowledgeable. No.
Fantastic.
Seriously, it is beyond my expertise. But this trial has proven that it does not matter at what time of the day you give the drug. So, and because of logistics, it's not really possible to give drugs to all the patients in the morning. Especially in busy centers, patients are going to come at all times of the day. So I think if it doesn't make a difference, it's a very good thing. That's my take on it.
Mr. Rami, what's your take? And then we'll have Dr. Ullas.
Yes, absolutely. Well, I think it was good to have this study because, as you know, the first study created a lot of buzz, and then for uncertain reasons, still now we heard there is some issues with it. We're waiting to hear the Nature paper and what happened, and maybe so scientifically it was a mind-boggling. We started creating some rationales: the body, the immune system, the circadian rhythm. I wasn't very convinced scientifically, but the data looked good on the first one. So in a way, I'm relieved now that maybe there is something to say, hold off, it's not yet. Maybe we need more. I don't know if anybody's going to do another. I heard there's a couple of other trials maybe going on. We also need it in different part of the world. There was a question if there is the population or something different. So as of now, I am not changing the timing. Especially with immunotherapy being a low, short time. As a matter of fact, in our institution, good number of them do get it a bit later in the day because we reserve the early spot for the long infusion. So as of now, I'm comfortable saying I don't know that the theory holds up. Let's see if there is more. But as of now, I wouldn't be pushing for earlier in the day.
Dr. Ullas, your take, and then we'll ask Dr. Drew.
So happy to see these results. Yeah, happy to see these results. Only two statements. When you torture a data long enough, it will confess to anything. That is what happened. And retrospective data, you have to take anything with a pinch of salt. But happy because this was turning out into being a nightmare. Again, you see, what is morning for me is maybe something else. The circadian rhythm is different. That is where you feel bench has to come to the bedside to really see. And thankfully, the common sense has prevailed. So happy to see these results.
Professor Drew, what's your take?
In the VA healthcare system, we've thought about doing a randomized trial. There's a large retrospective study, lots of patients, and with all the propensity matching, it does look like there is a benefit of morning, but the residual confounding risk is so high. Maybe there's just an inherent difference in people who get up in the morning versus get up at night. You get up later in the day and don't want to come in, into the clinic into the afternoon. But the idea that the pineal gland has a role is theoretically possible. But these data, I think, was a sigh of relief for medical oncology clinic schedulers, at least.
Yeah, thank you. Next slide. So I think this is the last slide we have. And let me share a paper presented by Dr. Akhil, who is one of our faculty. And he talked about the stool microbiome. So Dr. Akhil, can you just tell us about your paper, and then we'll take the views of the other faculties?
Yeah. So basically, a lot of data on microbiome is very rapidly evolving. As we see, there is two small studies for RCC already published in Nature, which have highlighted that incorporation of simple microbiome supplementation of CBM 588, that is Clostridium butyricum strain, adds to significant chances of responses to immunotherapy. So what this is a simple systematic review of multiple microbiome testing methodologies which we are adopting, and we have a randomized trial planned at our center called Fortify LC. That means At one arm, in one arm, we'll give pembro plus chemotherapy standard, and in other arm, this will be placebo controlled trial. Other arm will receive probiotics, which is CBM 588. So this CBM 588 is an over-the-counter probiotic available in Japan, not yet available very easily in all the parts of the world. But we have done some initial studies, and our data is looks very good. So we have decided to do a phase 2, going to phase 3 part of trial. So we'll start with phase 2, see the response rates. If the response rates are getting improved with the addition of CBM 588, we'll take it to a phase 3 trial. So a lot of things are again in the buzz, but we don't know whether the probiotics or these interventions will actually change the outcomes. But the initial studies and initial data is very, very promising. So it is quite fascinating. So we need to await more data to take into practice. But to me, after reviewing all the data, it seems quite promising, and we need to have more studies to take this into practice. Amol sir, you are not audible.
We may have lost him.
Yeah, I think
So we'll just wait for 1 second. Sir is just logging in.
Okay. In the meantime,
Akhil,
yeah.
Akhil, yes, I do think that microbiome is a fascinating thing to do, only for a very simple reason that it's cheap and it's worth doing. You spend millions and zillions of dollars with a lag story, the digit story, and then it comes to that. But I will caution everyone, as we caution for everyone, the phase 2 results, what you see initially in clinic, and what you finally see in a randomized control trial are different. So it's good. It's nice, it's scientifically sound, but we need to see the phase 3 results. That's what I would probably say on that.
Completely agree.
And I agree. If we have a second, first, congratulations, Dr. Kapoor, on this very important paper. This is amazing. I know the question for me was, do I believe? I believe in the concept. I think this is merit the trials. I don't test. Just even though it's a cheap test. I like not to order tests that I don't know what to do with the result yet. So I do not test for microbiome yet. But when family, friends, somebody bring it up, I actually sometimes have it in my slide because I think there is some you may know, looking at affecting response, predictive versus prognostic, following up some response and others. I think the field is expanding, and this is just the beginning, which is excellent. Kudos. But right now, when my patient asks me, I would say I'm not testing it because it just doesn't add much. We have other questions, not to compare ctDNA in monitoring response, right? It's not ready yet for prime time. There is a lot. So I'm not ordering something that I don't know yet how to interpret. But kudos, and keep up this great work, and hoping some trials can answer the questions.
Thank you.
So thank you. 1 second. Yeah, Akhil, please go on.
Yeah. So definitely, I completely agree. We need more studies, and we also do as a part of the study only, sir. I completely agree.
So let me come to the end of this webinar. We have a lot of issues with the internet, with the mobile range, but I really thank all my faculties, Dr. Patrick, Dr. Drew, Dr. Rami, Dr. Ullas, Dr. Sabita, Dr. Akhil, and of course our young colleague, Dr. Barnini, for taking time out for this academic activity. We all hope and pray for peace in the world and war to stop, so that hopefully we can, at least from India, go and attend such kind of conferences and let wisdom prevail in oncology as well as in the real world. So I thank all of you. Thank you very much. Thank you. Thanks, everybody.
Thank you, sir.
I'm sorry for overstepping on the time, but it was a wonderful discussion. I once again thank everybody.